All right, thank you very much for the honor of the podium. I'm Vahagn Nikolian. I'm from Oregon Health and Science University in Portland, Oregon, and I'm excited to talk about one of my passions, which is improving virtual care through telemedicine. In terms of disclosures, I'm a consultant and key opinion leader for Care Syntax, Medtronic, as well as Intuitive, though these are not relevant to today's conversation. The COVID-19 effect, it's impacted every single person in healthcare. Every single stakeholder has been impacted, for the most part, negatively over the last 18 months. Patients, providers, healthcare systems have had to make innovative changes to the way they manage and take care of patients. For many of us, I think the COVID pandemic has had a few silver linings, one of which has been the use of telehealth and digital health strategies to improve patient care. Today, we're going to talk about how we can use and leverage telemedicine to improve patient outcomes. We're going to talk about some prior successes. We're going to review some recent innovations that we've introduced at OHSU, and we're going to highlight some future applications of digital health strategy for patients, especially for ERAS. I've been doing telehealth since 2016. I was a resident at Michigan and had a lot of support from our department, and we rolled out what we called our Surgery E-Clinic. We started with a very safe population of patients. This was pre-COVID, and there was a lot of unknowns, and some considered e-clinics to be a novelty. And so we started with laparoscopic cholecystectomy, appendectomy, and straightforward hernia repairs. And we gave patients the option of a virtual encounter for post-op checks. We saw that it was a very safe approach. There was no significant difference in outcomes with regard to length of stay, readmission, ED visits, or mortality for these patients. More importantly, we saw that patients who engaged in a virtual or e-clinic derived significant personal gains. They had no drive time to the clinic, no figuring out a complex parking structure, or having to walk through or navigate a complex medical center. More importantly, they had a very efficient clinic appointment with most of the time dedicated to a face-to-face interaction with their provider. When we asked the patients what they thought, patient satisfaction was very promising. We saw the vast majority of patients were satisfied or very satisfied with all elements of care. We took a lot of this data and iteratively improved it as well. So that was the pre-pandemic era. Telemedicine was a novelty, definitely not the norm. And then COVID hit. COVID hit, everyone had to transition to a variety of new approaches to care, and telemedicine really took off. This is a screenshot of PubMed. If you just type in keyword telemedicine, and you're seeing there's a huge uptick in the quality of research that's happening and understanding of what patient populations we can support with this mechanism. We're very interested in developing a virtual hospital. OHSU 2025 was defined back in 2019, pre-pandemic, and one of our goals was to take our hospital on a hill. Whoever's been at Portland knows that we are legitimately on a hill, and change that impression that we have in our surrounding communities. We want to deliver that same care from the comfort of a patient's home. And so how are we doing it? Our AbWall program's really been enthusiastic about integrating virtual care into our patient populations. We've been increasing the complexity and the phases of care that we're implementing telemedicine. Specifically, we've been seeing more complex patients, ventral incisional hernias, or patients that require complex reconstructions are now having their initial evaluation through a virtual encounter. We review CT scans, we talk about preoperative optimization, we set the patient up for success well in advance of their operation. We're improving access to care. This is data we're very excited to share with you all in the near future, specifically looking at how our virtual clinics have improved access to care for patient populations that traditionally have had trouble being seen in like a quaternary referral center like OHSU. Rural populations, patients from lower socioeconomic status, and older patient populations that require a fair amount of coordination of care are having improvements in their access. For select straightforward diagnoses, we're actually now providing 100% virtual care. We no longer require physical space to see the patient and tell them what's wrong or make sure that the operation we performed went well. So about 25% of my cases, especially straightforward primary hernias or inguinal hernias with image-guided diagnoses, we're doing exclusive virtual care, with the only in-person, face-to-face encounter happening around that day of surgery. Postoperative care has been significantly improved, and we have a variety of strategies now in place to minimize the number of times a patient needs to come to clinic. Traditionally, we used to say if a patient has a drain, they have to come back to our clinic or a local clinic to have it removed. We've now instituted digital health and digital drain removal strategies for patients. We watch them at home from the comfort of their own bed, remove their drain with no adverse events and a great deal of patient satisfaction. We have a virtual surveillance program which has helped with our ability to actually record what's one of the most important data elements for us, and that's patient-reported outcomes and our ability to monitor and evaluate for recurrences long-term. We're leveraging all of this now to really improve and change the dynamics of the hospital setting. So what I'm going to talk about now is the concept of hospital at home. And this sounds, novel, but it's actually been described in non-surgical patient populations. We're now working towards giving patients who have straightforward operations, who usually require a 1 or 2 day hospitalization, to have the opportunity to go home and have a paramedicine nurse visit them, Q6 hours, check vital signs, give them IV infusions, administer drugs through their IVs, as well as get diagnostics remotely. Our paramedicine nurses will staff patients with us in the hospital. They'll get us mobile laboratories if we need them, and we'll have the ability to remotely monitor patients in the acute recovery period, freeing up beds in the hospital, allowing for patients to have the hospital beds when they really need them. So why hospital at home? First and foremost, it's patient-centric. We think that it's going to address a lot of the ongoing capacity issues that many hospital systems face. We think that we're going to be able to increase inpatient admissions beyond the walls of our institution. And we're analyzing it soon, the cost effectiveness and the value that we can deliver to patients. So in conclusion, telemedicine is here to stay. It's just a matter of how we use it. New applications in the technology will enable us to have better patient-centric care. And strategies like hospital at home have been described in non-surgical populations, and it's on us to look at how we can implement this for surgical patient populations. With that, I want to thank you, and I look forward to a discussion at the end of this session.